Welcome to the Advanced Practice Life and Emergency Medicine video on the approach to chest x-rays. This video is designed to help you come up with a systematic approach to reading a chest x-ray. Despite having radiology frequently reading your x-rays for you, the emergency medicine provider should possess this fundamental skill of being able to interpret a chest x-ray. Every chest x-ray should be systematic, and you should develop this same repeated process every single time. Just make this a habit. Before beginning, I think it's important to quickly talk about why we would get a chest x-ray. Some of these indications would be, of course, chest pain, productive cough, dyspnea or shortness of breath, cough in the setting of weight loss, and any focal chest signs or symptoms on your exam. Equally as important is identifying the difference between a PA and an AP view. You'd be surprised that some of this gets missed in school. PA, or posterior anterior, the patient is standing with their chest facing the detector, and the x-ray is taken from behind the patient. AP, or anterior posterior, the detector is placed behind the patient's back and the x-ray is taken from the front. This is the method used for a portable chest x-ray. This may sound very basic, but just begin your initial review of the image with identifying that you have the correct patient. What is the patient's chief complaint? This will often be the reason you ordered the chest x-ray in the first place. And when the x-ray was obtained, ensuring you're viewing the most up-to-date exam. You also want to evaluate the quality of the x-ray to ensure it is not under or overexposed. Next, you'll always want to review lines and tubes first and foremost. This means evaluating endotracheal tube placement, if present, nasogastric tube, central venous catheters, and any other lines or tubes like a chest tube, for example. After you've reviewed your lines and tubes, if they are present, we'll move on to the ABCDE systematic approach to interpreting a chest x-ray. So, like all of our other assessments in emergency medicine, we'll begin with evaluating the airway first. We'll start at the top of the image and trace down the trachea, down to the carina, noting that the trachea appears straight and midline. We'll continue to trace down both main bronchi, noting if the carina appears wide or narrow, and if there is any bronchial narrowing or dilatation. Moving on to the B in breathing, we'll examine the lungs for any lung or pleural pathology. Both lungs should be well expanded and similar in size and volume, noting any size volume abnormalities. You should be able to count 10 posterior ribs bilaterally. Compare the apical, upper, middle, and lower zones to ensure symmetry or any areas of increased density. Next, we'll trace the lateral lung margins down to the costophrenic angles, ensuring they appear nice and crisp. Then trace the hemidiaphragms to the midline, ensuring you can see the entirety of the hemidiaphragm. Lastly, trace up the cardiac borders, ensuring the left and right heart borders are clearly visible. Okay, next, moving on to circulation. Here we're examining the heart and vessels. We want to note the cardiac position and size. We'll want to examine the position and size of the aortic arch and check the width of the upper mediastinum. Lastly, we'll look at the hilar vessels, ensuring we can see them clearly on both sides. Now we arrive to the D in disability evaluation of the chest x-ray. We're checking for any bony pathology, beginning by tracing along each posterior rib horizontally on both sides of the chest, noting any potential fractures or any other abnormality such as a punch-out lesion or lucency. Next, we'll do the same thing and trace the lateral and anterior ribs. I recommend approaching one entire side at a time rather than breaking it up and looking at both sides all the way across. This allows your eyes to adjust and switches your areas of focus. Now let's move up to evaluate the clavicles and shoulders, being able to trace around the cortex of the bones. Lastly, we'll want to evaluate the vertebral bodies, assessing that they all appear rectangular and of similar height, ensuring you can visualize 2 pedicles per vertebral body and that their disc spaces are present. Lastly, the E in our radiologic evaluation of chest x-rays stands for exposure. Here, we are looking at everything else not previously evaluated, such as the upper abdomen and soft tissues. We want to be able to identify if there's any free air under the diaphragm. Are there any hiatal hernias present? Or are breast shadows present or absent, such as in this case? So that will wrap up our systematic approach to interpreting a chest x-ray. Remember, using the same process every time will reinforce this until it becomes second nature. And always remember, if you want to befriend your local radiologist, just tell them that dogs can't operate MRI machines, but cats can.